Okay, I'm going to talk now this afternoon about abbreviated breast MRI, which I think, how many people here are offering an abbreviated MR protocol at their site? A couple people. I'll talk about, our trial, the ECOG Akron trial, and there's a website I've seen, I think it's called The Time to Be Seen. It's kind of like the RU Dense grassroots website, and it lists, since the trial, there must be 80, 90 sites offering abbreviated MR, and it lists the cost, how, what sites offer abbreviated MR and what their cost, and, if they offer full and abbreviated, et cetera. Here's my disclosures. And so the topics we'll talk about are the protocols, because there's really no set protocol for abbreviated breast MR, patient selection, how you educate the patients and referring physicians, and then kind of the patient flow and billing, et cetera. So there's really, the minimum you have to have, obviously, for an abbreviated breast MRI is a pre and a post contrast. We tended, at least on the baseline study, particularly if you don't have comparison studies, on their first MR, it's nice to have a T2 weighted sequence so that if you do see a mass, it looks benign, and if it's bright on T2, that I think it helps improve your specificity. So to reduce your callback rates or short-term follow-up or biopsy rates. And then, but it does cost some time, about 4 minutes or more, so it adds time to the protocol. So the whole premise of abbreviated breast MRI is, why have we limited our most sensitive test to just, the high risk according to the ACS guidelines, the super high risk patients. And if you could do a patient in 10 minutes versus 40 minutes or so, you could do potentially like 3 patients in one slot. Obviously, there's table on and table off time, so you can only minimize it so much. But depending on what your regional reimbursement rate for an MR, if it's $1,200 or $2,000 or in that range, you could probably, if you do 3 patients at the price of 1, you could get the cost down to $400 or $500. So you could, administrators don't like to do a new procedure that makes your reimbursement hourly rate on your magnet drop below what you're already reimbursing it for, and so when I took over the ECOG Akron imaging co-chair. I had done a fellowship in multi-center trials and Akron fellowship under Bruce Hillman and Mitch Schnall, and so through that program, then I got involved in Akron, and a lot of the data, obviously, Christian Kuhl has been involved and a big pioneer in abbreviated breast MRI. But if you look at most of the, if not all of the data showing it was comparable to full MR in terms of sensitivity was they were reader studies where the patients had a full MR, but then they stripped out some sequences and did a reader study. So we really wanted to do a study where the only sequences the patient got was the true abbreviated MR. So we embarked on this multi-center trial comparing abbreviated MR to patients getting screened with tomosynthesis. It's a very similar design to some of the other trials like Wendy Berg's whole breast screening ultrasound, where patients were scheduled for just a routine screening DBT, age 40 to 75, but they had to have dense breast tissue, so categories C or D, and they had to be asymptomatic. They couldn't have had a prior MR or contrast mammo, because we know the effects of, and I'll talk about the data, when you get a vascular screen, it sweeps out a lot of cancers, and that can drop your incident rate quite low for probably 2, 3, 4 years. So these patients hadn't had a prior MR, but in order to know they had dense breast tissue, they all had to have had a prior mammo. So there's a little bit, so the tomosynthesis had a bit of an advantage on that first round because the people reading the tomo had comparison versus the MR, the abbreviated MR, the patients had no comparison. So you expect the callback rate and biopsy rate to be a little higher on that baseline. Surprisingly, it didn't get much better on the second round. I think I have slides about that. But so they volunteered to do both. They're already getting a tomo for their annual screening. They volunteered for the ABMR, done, I think it was within 24 hours, and read by separate radiologists. And then they got a baseline, and then they got another one a year later, and then they were followed for 3 years. So we published the results in JAMA in 2020, and the data is pretty amazing. some of the information from the trial that was important, not just the cancer detection rate, but when you do these phase 2 studies, is how does the test perform, how do patients tolerate it, et cetera. So there were 46 centers that participated in the trial. One was Christian Kuhl's site in Germany, but the rest were all in the United States. And they were a mix of private and academic practices. So you don't want to do a study where it's all just academic centers, and then when it's used differently, the results might vary across if you're a private practice or community hospitals. But pretty much most of the sites weren't offering abbreviated MR. They obviously had to know how to do breast MRI, but they were able to do the scan in less than 10 minutes and 97%. The average scan time was 8 minutes, and this included a pre, a T2, and a post, and obviously a localizer scan. So that was all done. And the women were actually able to tolerate it. 96% of women who volunteered for the study were able to complete their MR. Because there have been, previous ultrasound screening studies saying, oh, you can't do MR, patients don't tolerate it. Well, when a woman knows when they volunteer for these studies that, they may have a better chance of having their cancer detected, having an injection for a screening test isn't that big of a deal. We're even working our patient-reported outcomes, which show that patients are very highly accepting of the test. And there were only 12 minor reactions, no serious reactions. So here's the data, and what's really amazing, it was over about 1,440 patients, and the TOMO found there were 23 women out of that group on the first round of screening, the prevalence round, that had cancer. The TOMO found 9 of those women. The 8-minute MR found 22 out of the 23 women with cancer. So it's pretty high. You almost would say from this, why do the TOMO if you're finding 22 out of the 23? Well, I'll tell you about year 1 screening. The TOMO is picking up some high-grade DCIS not detected by the MR. And it actually powered the test. When we presented this to the NCI, they wanted it powered to invasives so that, we were finding important cancers. But, we know that vascular screening like contrast mammo and MR detect the biologically, higher grade cancers compared to mammography. But also important is that there were no additional invasives detected by DBT. All 7 of the TOMO detected invasives were detected by the MR plus 10 more. And there were 3 high grades that none of which were detected. That wasn't powered. It's kind of anecdotal, but all 3 high grades were missed by the DBT. I have a slide. I didn't put it in here for this, but I have this slide of the 22 women with their cancer detected, and 13 walk out the door if they didn't volunteer for the study, not knowing they had their cancer. So it's a pretty almost a 2.5-fold increase in cancer detection. So it turned out to be, and these aren't high risk. We excluded high risk. So these are women just with dense breast tissue, either categories C and D. They could be average to intermediate risk, but not high risk. And there were 15, a little over 15 per 1,000 cancers detected by the ABMR, and only 6 per 1,000 detected by the DBT with no interval cancer. So it's a pretty powerful jump in sensitivity. Now, this is interesting when I talked about the year 1. Now, this is they had a screening a year later, and now the ABMR, right? The reader has a comparison ABMR. You would think the PPV of biopsy and the recall rate improved a little bit, but the PPV of biopsy didn't really change. I'll show you that in the next slide, but. So this is what you expect when you introduce a very powerful test that can find cancers at a smaller size. You sweep out this reservoir of cancers that are being missed, that are there but just are below the detection of mammography. Once you've swept those out and you continue combined screening, the test that can find the smallest cancers predominates in the invasive detection. So we can see here at year 1 screen on the lower right, there were a 3-fold increase in invasives. But you can see here that the overall cancer detection was higher with the MR, but it's because the TOMO found 3 DCIS. So there were 6 invasives and 3 DCIS, all 6 invasive detected by the ABMR and only 2 by the DBT, but 3 DCIS is detected by the DBT, not by the ABMR. I don't have the slide, but the PPV of biopsy still stayed around the baseline was 19%, which, we'd like our PPV of biopsy to be about 20 to 40 on the next round, but it wasn't statistically significantly different from the tomo, but it's still below what we expect. This round, 1 year screening round, it was only, it was like 15% PPV. So we need some work. I think that's where AI and interpretation tools will help us reduce the number of unnecessary biopsies and short-term follow-ups for MR. So as I mentioned, there was, for the trial, it was the EA1141. We had a specific protocol, which was kind of along the lines of the breast MR accreditation program, 1 millimeter less in size voxel implane, and then less than 3 millimeters slice thickness. And this was, as I presented earlier, this is kind of our initial, we did some ultrafast in this trial, but that was just exploratory. We didn't use that for the interpretations. But as I mentioned before, Sarah Winkler's data, I showed you this, I'll just jump to the slide, that having that ultrafast early on, particularly in patients with BPE, can drastically increase the sensitivity in patients with high BPE. So I think if you're doing an ABMR program or starting it up, you should incorporate some type of ultrafast for that first. You could do an ultrafast for 60 seconds, let's say 4 15-second phases, and then switch to either your gradients or do a longer ultrafast for a better resolution scan. So now I'm embarking, knock on wood, hopefully it was promising meeting with Gerbet at RSNA about funding. Actually, it's Liz Morris. She asked me to design the trial, but she's been working with Gerbet on funding what I call smart ABMR, and kind of from the lessons we learned of the first trial. And that's that I think a patient should have a more robust baseline, right? And we're only talking to 12, instead of 8, we're talking 12-minute scans. But the model would be you do, your T2, we do ultrafast, a pre and post-contrast. So we would do, about 4 minutes of contrast scanning. That would give us a little bit of kinetics, and then we'd also have diffusion. And so we can wrap that up into about a 12-minute scan. And then going forward, we're just going to do that ultrafast 4 minutes of contrast scanning. Because if you have a new, so we're just using, so they're, most of their scans, when a patient has a baseline and they get scanned for 20 years, it's that incident round screening that they're going to experience. And so that would just be a 3 to 4 minute scan. And because you're really just looking for change, right, between the last scan and this scan. If you have a new enhancing mass, does it matter what the T2 signal is? You need to biopsy it, right? Or if it's a new mass, but you have kinetics that shows it's benign, you still need to biopsy it. So that additional information really, when you see a change, a new mass or new non-mass enhancement, those extra sequences aren't really going to help you. So they're just wasted time. So we hope to run this not as a paired design, but as, which I think the trial I designed for this is just a supplemental, right? So this would only be patients who had a DBT and they had no cancer. So maybe they get a core biopsy, it has atypia and they have to get surgery, and then that turns out to be benign. But we need to make sure they don't have a cancer. So then we'll have the performance of the tomo and how many cancers. But for all the patients who didn't have a cancer, then we do this smart ABMR program on, and we see, does it detect, what we expect, 10 extra cancers per 1,000. So it's a very compact design, and then we'll see how these subsequent years perform just doing the Christiana Cool 3-minute, scan. So, using ultrafast, this is probably too much information from our protocols, but we do these different phases, but they're 7 phases, and the first phases are only 20 seconds, and then we go up to 43 seconds on the rest of the phases. So patient selection, right? So we've talked about designing your protocol. You can just stick with a pre, post, and a T2, if and like we did with the ABMR trial, or you can try some of these newer, incorporating ultrafast or this smart design. But who would you offer it to? Right now, we don't offer it. We already have like 4,000 patients at Sloan Kettering getting combined mammo and MR, full MR, who are high risk. Gene carriers, they've been genetically tested, or they have models that show they're high risk according to the ACS guidelines. So I think there's some people that are using ABMR on their high risk screening patients. I'm not sure we have the data to really, we've had years of data from full MR and showing the benefit on high-risk patients. I think eventually we'll get there, but I think we need more comparison, and the premise may be, but those high-risk patients, you might say, well, why do different scans on the two? Well, the high-risk patients we know have more proliferative tissue, and they're forming more cancers. So they may have a higher rate of, false positives and, high-risk lesions, et cetera. So I think having more sequences to really maintain your specificity. But I think eventually when we have the data, I think it's probably going to work out just to be one model, particularly if you do that baseline robust scan that should serve everybody. And but right now at Sloan Kettering, we're offering it only to people who are not, who shouldn't already be getting full MR, but they have dense breast tissue based on their prior mammograms. So full MR, we use the ACS guidelines, gene carriers, patients with a greater than 20 or 25% lifetime risk. And we know we have the data from the MR, and most of the data previously on MR has been on high-risk patients, and we clearly know that MR is our most sensitive test compared to mammography and ultrasound. The ACS guidelines, obviously, gene carriers, different models you can use. I won't go into the detail. The models do have different. The same patient can, depending on their ethnicity or history of previous biopsies or family history, you can use one model and get a 15 or 18%, and the other you'll get 25% risk. So there's some variability there. There's these new kind of guidelines or recommendations from the ACR, which I think they have more variability in whether insurance pays for these categories or not. The ACS guidelines, most of the insurance carriers have picked that up, and those patients, if they're a gene carrier, automatically would get reimbursed. So if you have a personal history of cancer and you have dense breast tissue and you're older, or you're young and less than age 50 diagnosed with cancer, and it doesn't matter if you're dense or not. And then these other potential patients, if you have your young age, or you have ADH or LCIS or ALH, et cetera. What about educating the patients and referring physicians? We're embarking on this program at Sloan Kettering because now we do about 12 contrast mammos a day. We do over 20 MRs a day. We have tomo, whole breast screening, ultrasound, and they're kind of in this mix of what should I order? And we're really trying to work on more of a tailored approach. Kind of stepping up, the higher your risk level is, the higher you go, up to full MRI. I think contrast mammography falls a little bit below MR in terms of sensitivity. So, and then also patient preference. Patients may say, I don't want any false positives, and I don't care if it's not the most sensitive test. Or the patient may be, I don't care how many false positives, I want the highest sensitivity. So I think it's a patient and referring physician decision. Several centers have offered, University of Pennsylvania and Cleveland here have programs. They shared their information of these different patient cards that have educational information. Some people call it a fast ABMR. Some people call it, we call it abbreviated breast MRI, but right now we don't have, there's a whole, I don't know if I have slides, but, we'll talk about the payment issues associated with it. But, this is kind of education for the referring physicians and patients in terms of what is a shortened MRI. And so there's different, like to the right is something we created for Sloan Kettering, given, the different tests, abbreviated MR, contrast mammography, whole breast screening, ultrasound, what the differences in terms of sensitivities are. So we go ABMR is 150% increase, contrast mammo 100, whole breast screening, ultrasound 50. What's the risk of, false positives or additional biopsies? Moderate with abbreviated MR and contrast, pretty high with your baseline ultrasound, right? And then also the instructions, the process for referring physicians. Let me see, do I have a... if we have this screening, obviously the patients, you want to make sure that they don't fall into high risk category, or we get somebody who they've been getting full MRs, they're bronchocardia, and now they're asking to be done on the abbreviated program. So we kind of screen patients in that regard. So there's a whole, problem with the whole issue of CMS codes. There's only one CMS code for breast MRI, right? You can use a modifier to reduce the charge, make like a limited breast, with other, it's not just specific for any MR, can use a modifier that's like a limited study. But the problem is if they don't qualify to get paid for a full MR, they won't get paid for an MR with a modifier. So it's variable. I know some people in various cities who started up ABMR programs have talked to their insurers saying, this is actually beneficial for you in terms of saving costs down the road, saving on chemotherapy and, lumpectomies versus mastectomies and things like that. So the variability, Sloan Kettering right now, it's a cash pay. We offer it for $495. That's the Manhattan rate. But University of Pennsylvania has been offering it for, Emily Conant, they've offered it for probably 5-6 years for $299. They found it more efficient than their whole breast screening ultrasound and more sensitive. So, it just depends how it works into your, patients can submit it to their insurance, and whether or not they get insured, it's, just billed as an MRI. But the code for an MRI doesn't specify what sequences you have to do. And the ACR doesn't want to get into the game of new codes for different, like calling it something else, because there's no specification on how you make your protocol. So really, we're kind of, until there's uptake and patients kind of forcing their insurers to think about or consider, or CMS consider creating a reimbursement code. Right now, it's an out-of-pocket expense if, for whatever reason. Now, I put a caveat on that. There, some states with the whole breast density legislation have mandated insurance for supplemental screening with MR. But even in New York, I think that's in the law that they have. But there's some way that the insurance companies can get around it and not reimburse. So it's kind of variable. But some, with this new density legislation, you may see that you'll get reimbursed for some of these studies. So we have a whole process where the patient, gets screened, and they get notified that they're going to be contacted by billing to, and last thing we want to do is have them show up for their scan, and it's like, oh, you haven't paid, we can't do the scan. So we basically want to try to get that set up front so that like a week in advance, so they come in and they've already gone through the billing process and they come and get their scan. So other questions? I think it's important to schedule if you can, during the second week of the menstrual cycle, just to reduce, the busyness of the pattern when you're interpreting it, and potentially false positives, et cetera. I think they should have a negative mammogram at 6 months. I don't think, patients should be getting both mammography and MR if they're getting supplemental screening. So I think that's something you should see, that the patients are at least getting mammography. You don't want to use ABMR for somebody coming in because they had a lump, right? You don't want to do symptomatic patients, or they had a callback from their mammo and that hasn't been sorted out and now they want this MR. So again, I mentioned that currently there's no CMS code. If it's not covered for full, they're not going to be covered using a modifier. It's out-of-pocket expense. One of the issues of enlarging our access to screening breast MR is just the number of magnets available. Fortunately, at Sloan Kettering, in our building alone, we have 3 magnets. They probably do 40% breast. And we don't have a big problem. We do 3 biopsies a day, MR biopsies, plus about 20 MR, breast MRs. And if, for whatever reason, we have the ability to get patients in if there's some emergency why they need a breast MR. I know other centers, they have to fight to get time. I think the new model really should be going, in the future, is breast centers need their own MRs. I mean, the volume is there. I don't know if you remember back in the day, Steve Harms had a company that was 20 years ago, embarked on a dedicated breast MR. And I had a debate with my former chairman about, her opinion was you can never have a dedicated MR unit. And my argument is name one other screening application for MR. It's only breast. You don't screen for brain tumors or things like that. So there's most other MR is for diagnostic purposes, right? Like you had a abnormal PSA or you had some other type of diagnostic reason for it. And so it's funny because when Steve came out with this dedicated magnet, we're only doing high risk patients. So if you're doing 3 or 4, even 5 breast MRs a day, if you have a dedicated breast MR magnet, it's going to sit idle for most of your day. And so actually the company kind of pivoted and used a trailer that would stop it in sites so you'd have it to do your volume and then go to another center. But it was ahead of its time because now the volume's there. I think with abbreviated MR, more and more patients getting MR, you can justify if you're doing 20 or 25 a day, you could justify doing, and plus biopsies, you could justify a dedicated MR. So I think times are changing, and I know some companies, particularly in China, that are working on low cost, like $600,000 dedicated breast MR magnet, and they want to make it, you saw Bonnie Jo's some of those technical slides. They want to use AI and things so that the technologist can put the patient in the magnet, and AI just takes over and it tunes and sets the scan up. So it takes a lot of the technologist's time and skill out of the equation. So those things are coming. We see that for all other aspects of CT and MR. AI is being used to improve the quality and tune the study, tailor the study to the patient. So I think the model will be, in the future, breast centers really need their own magnet, and they can offer abbreviated MR, they can do biopsies, they can do full MR, and response to therapy, everything. But I think there's probably almost 90 or 100 sites now that are offering abbreviated MR, and I think we'll see more and more. So I think our study, our trial on abbreviated breast MR achieved its goal in really expanding access and awareness of the power of breast MRI. So I hope, if you have any questions, feel free to contact me. And if you're starting up an ABMR program, you want to kind of define your protocol, decide your patient selection, get your referring physicians on board in terms of, education and the workflow and how the patients get set up for the scan and screened and how they sort out their billing issues. So I hope those of you who aren't come on board to the new paradigm in breast cancer screening. Thank you very much.